This episode of the Nurse Practitioner Podcast is sponsored by Dakins. When you're treating persistent, hard-to-heal, or complex wounds, you need a solution you can trust, like Dakins Wound Cleanser. Just how powerful is it? Dakins Wound Cleanser has been proven to kill even highly resistant bacteria like MRSA and VRE within only 30 seconds. It's non-cytotoxic, shelf-stable for 2 years, and more cost-effective than other wound cleanser brands. When you need a solution you can count on, ask for Dakins. In this episode of the Nurse Practitioner Podcast, Tate Cutshall discusses drug-drug interactions, adverse events, and transitions of care.
My name is Tate Cutshall, and I'm a clinical pharmacy specialist in internal medicine at Methodist University Hospital located in Memphis, Tennessee. I also serve as an assistant professor at the University of Tennessee Health Science Center College of Pharmacy, and I'm also the program director for our PGY1 pharmacy residency program at MUH.
What is your current role in the hospital as a clinical pharmacist, and what are your interactions with NPs?
In my current role as an internal medicine clinical specialist, I serve on one of 3 medicine teaching teams that comprises of an attending physician, medical residents, medical students. We also have 4 non-teaching medicine teams that a few of us kind of cover peripherally. And on these kind of 4 non-teaching teams, it comprises of an attending physician, but we also have an admitting nurse practitioner during the day that assists with admissions for these teams. In my teaching role, I round with the team on patients and assist them with creating and optimizing drug therapy regimens, educate them on new literature and new policies that we're rolling out as a hospital, assist them with transitions of care, and also manage certain medications independently, like vancomycin dosing, warfarin dosing, and total parenteral nutrition, among just a number of things. In addition to my role on the teaching team, I cover an additional number of beds in the hospital for certain units. This is where I pretty much do the same thing for my patients on my teaching team, but I also verify inpatient orders for patients on the medicine side. And so this is where I'll often interact with nurse practitioners and physicians outside of my teaching team to help them clarify orders or address any issues with the orders that they are putting through. We have a few private MDs that I interact with that have nurse practitioners that help them with their patient care responsibilities throughout the day. And so I work with them a lot throughout the day to assess any medication reconciliation issues, drug therapy optimization, transitions of care, and also assist them with antimicrobial stewardship.
Thank you for that information. How did you come to be involved with the Nurse Practitioner Journal?
So about 4 years ago, a few of my colleagues were working on a case report looking at a drug-drug interaction between ciprofloxacin and rasagiline, and we ended up submitting it to the journal. Since then, anytime I found an interesting drug-drug interaction or an adverse effect of a medication that's unique or rare, I've primarily submitted it to the journal because the journal's been very cooperative and very easy to work with. And nurse practitioners play such a large part in prescribing and taking care of patients, both inpatient and outpatient. And, what I've heard from my nurse practitioner colleagues, much like I hear from my physician colleagues, is that they don't really receive a ton of pharmacology training in school. And, this creates a huge opportunity for us as pharmacists to really help and assist our nurse practitioner colleagues with drug therapy questions and information. So again, anytime I see some of these interesting adverse events or drug-drug interactions, this is something that nurse practitioners can, be faced with each day. So I think it's good to kind of get that information out to them so that, when they encounter those issues that, they know what to do potentially.
We appreciate your contributions to the journal over the years, Tate.
Yeah.
What is some general advice you would give to NPs about drug-drug interactions and adverse drug events? How do you usually approach this in your practice?
Yeah, so I think, if you were to ask any pharmacist, they probably think the same way. And I think the way that I was taught is that, anything and everything is medication related until proven otherwise. Now, obviously, I think we can agree that medications do wonderful things, but they're also not benign by any means. I think, in fact, as a healthcare provider, sometimes I think we get desensitized to how these side effects, can make patients feel. For example, a few years ago, I was working with a provider and he had started taking a statin. And, after a few days of taking the statin, he was complaining of, myopathy and muscle pain. And, he didn't realize how common it was with statins. And, we prescribe statins all the time. Similarly, to how we prescribe antibiotics for patients and how that can, upset patients and their stomach and GI side effects that we see with those. So I think, first off, I think we have to get the mindset of, all medications have side effects. And we need to be aware of that. We need to be educating our patients on those side effects. If you have access to a pharmacist, then they're probably doing all of these things that I'm going to mention, but it's probably not a bad practice if you don't have a pharmacist to start, implementing some of these things into your practice. Now, I know nurse practitioners and providers are kind of thinking about things more on a global scale, and we're really honing in on medications from a pharmacy standpoint, but these are some tips that I have to kind of look at and, maybe implement to your practice. So the first thing I do is, I make sure that we have an accurate medication history. I think this is one of the most important things that, takes place as a patient gets into the hospital setting or, is coming to you for the first time in an outpatient setting. I think some important questions that, we need to answer are, what drug are you taking? What's the dose? What route do you take? What's the frequency in which that you take the medication? How do you take it? At home versus how is it actually prescribed? Because I feel like this is a pretty big discrepancy. Sometimes patients may take double the medication or may take it half the time like they should. So I think this is kind of good to kind of tease out from patients. But also, what's compliance like? I think sometimes, when we ask patients, do you take this medication every day? Of course, they're going to say, yes, I take my medication every day. So the way that I really pose the question is, how many doses would you say you miss a week of your medication? I think this really kind of asks the question in a more pointed way that maybe gets a more honest answer out of them. Then I also ask patients, is there any trouble affording the medications that you're currently taking? Because although it pops up on a medication list, or they may say that they are taking it, they may have issues prescribing it. I've talked to a number of patients that intentionally space out their medications so that they can make it last. And so, again, that's where we can maybe intervene and find more affordable solutions for these medications. And then also, are there any over-the-counter medications or supplements that these patients are taking? Because oftentimes we can see some drug-drug interaction here that patients are taking. I preface all this to say that we have a inpatient pharmacy technician-led med history service, which is great. All of the patients that come in the hospital are seen by our pharmacy technicians that do a great job and a thorough job of talking to our patients, calling their pharmacies, and really validating what our patients are taking. So if you have access to that, that's awesome. If you don't, hopefully some of these things that I've kind of mentioned will help kind of give you a better way to maybe do a good, thorough medication history. After obtaining a good history, I usually run a drug-drug interaction check on medications to see if there's anything that could be causing issues or any modifications that need to be made with the patient's drug regimen. If I find significant drug-drug interactions, I think it's important to ask a few questions, find out, who prescribed the medication. Was it multiple prescribers that are prescribing these medications? Is it the same prescriber prescribing all of the medications? I think this kind of helps us determine, was it a neurologist that prescribed the medication and then the primary care doctor prescribed other medications? This is good information to have if you do find issues, to know who to kind of talk to and who is aware of, which medications the patient's on. There probably needs to be a bigger discussion on what actions need to happen next if you do find issues. Being on the inpatient side of things, there's definitely a balance of how do I approach this issue? Do I change a lot of things that, is happening with this patient's drug regimen, or do I kind of let some things go? Because ultimately, these patients are seeing doctors and nurse practitioners probably, and have been established for years. And so it's kind of one of those delicate balance things that you want to kind of take into consideration. And so I think that the easiest thing is to just pick up the phone and call these providers and really get a better understanding of what we're finding on our side with these medications, and if they're aware of certain things that, we're finding. A good example of this, I think, is we have patients that come in on anti-epileptics a lot, such as carbamazepine and phenytoin, and we have a very high patient population with AFib. And so they're taking oral anticoagulants like apixaban. There's a major drug-drug interaction with carbamazepine, phenytoin, really a lot of these anti-epileptics with apixaban and some of our other oral anticoagulants. And so this potentially could put the patients at risk for stroke and a high risk for stroke. And so this is really where, you don't want to just change somebody's anti-epileptic therapy. You want to make sure that, there's discussions involved and that there's a solid plan after you found this drug-drug interaction. And then after this, find out when the problem started. So if the patient is complaining of some side effects, find out when that problem started occurring for the patient and see if there's any new medications that had been started around the time of symptoms starting. Sometimes medications can cause these effects within hours of taking the medication. Sometimes it can take months for these interactions to really, or these events to kind of manifest. If you find out that there is a medication that is kind of started around the time that the patient started, complaining of a certain reaction, look it up and see if, that medication is linked to any of the side effects that are listed. Sometimes this is a guessing game, though. I'll preface all of this to say that, if you have issues or adverse drug events, it's kind of a guessing game of, is this the medicine or is this just a metabolic issue that the patient's experiencing? So you may elect to stop the medication and monitor the patient off the drug, or just kind of see how they respond, or change up the medications around a little bit to see what happens.
Thanks for sharing those helpful tips. Are there any tools or resources that you use to assess and analyze drug-drug interactions and adverse drug events?
So there are some really great tools out there that can check for drug-drug interactions, identify pills too. So if you have a patient that has a pill box and they bring it to you and want to know what they're taking, there's good pill identifiers out there. Also, if you work on the inpatient setting, a lot of these references that I'm going to talk about have IV compatibility questions that they answer to see if certain things are compatible running through the same line. And the two primary resources that I use on the inpatient side are Lexicomp and Micromedics. These are usually systems that require a subscription. So fortunately, through our hospital and through the College of Pharmacy, I have access to Lexicomp and Micromedics. And the good thing about these is that you can add allergies into your drug-drug interaction screens. So if you have a number of patient allergies reported and you have a number of medications that you're maybe considering starting on the patient or the patient's already taking, you can plug all that into the analyzer and it'll tell you if there's any issues there. It also gives you information on how to manage these drug-drug interactions and adverse events, severity that you can expect from that drug-drug interaction, generally speaking, and just other possible drugs that could interact as well. And the good thing about these references is that it gives you literature to actually support these interactions that you're finding. So it actually tells you if there's been case reports or bigger analyses that have been done to kind of give you a more detailed response on how these interactions kind of manifest and what's the likelihood that you'll experience those effects. And so it may or may not have the onset of time too, which is good information to have as well if you're kind of trying to pinpoint when this started versus when the patient started taking the medication. So those are personally the two references that I use the most commonly. If you're in a situation where you don't have a subscription or you're not able to get Lexicomp or Micromedics, there are a number of free resources. I was actually talking to one of the nurse practitioners in our hospital the other day, and she mentioned that she uses Medscape a lot. And so WebMD or Medscape have a free database that you can use. They give pretty generic descriptions of interactions that you may encounter, but it is a good free resource. Drugs.com is also another resource that's out there. The good thing about this resource is that it actually gives you kind of consumer information as well as professional information. So if you're wondering how to relate this to a patient, you can go to the consumer tab, versus if you want a more detailed kind of data, professional driven information, you can go to the professional tab and it'll tell you kind of some of the literature that supports the drug-drug interaction that you're seeing. So that's from more like a drug-drug interaction checker. If you're looking at adverse drug events, you're trying to determine maybe, is this the drug causing this, or is this something else that's happening with the patient? There is a resource called the Naranjo Adverse Drug Reaction Probability Scale. That is a mouthful. So usually if you just Google adverse drug reaction probability scale, it will come up. And this is scaled from 0 to 13. There's a number of questions that this adverse drug reaction scale kind of asks you. So it's a good prompt to kind of use to ask your questions to the patients. And based off of how they answer those questions, it gives you points for each question. And so obviously the higher the number, the more likely that it is the drug causing the issue. So that's a good resource to use as well. Again, I preface all this to say that general diagnostics still need to be done. From a pharmacy standpoint, we're always focusing on medications. So, but this is something good, again, to, I think of and maybe, use some of these resources in your practice to better maybe solve some of these medication mysteries that you may be encountering in your practice.
We appreciate you sharing those resources. You mentioned that you assist NPs with transitions of care. Could you elaborate on how you assist with this from an inpatient perspective?
Yeah, so, I mentioned that we do have pharmacy technicians that do medication histories, and so they do a very good job and a very thorough job of this. After they do their medication history, we get an alert from the pharmacy side of things to assess those medications and assess the admission history. And so we'll go over all the medications, look for duplicates, look for drug-drug interactions, and we'll, if we find issues, we'll escalate that to the providers. We also, review those medications to see what needs to be started in the hospital. For example, if a patient's taking Keppra or something for seizures, we probably need to start that pretty soon so that the patient doesn't go without that medicine for too long. If patients are on baclofen, baclofen has a very significant withdrawal potential. And so we don't want patients to go without some of these medications and potentially cause more problems in the hospital. So that's sometimes where we as pharmacists can kind of message providers and get some of these medications started sooner rather than later. A lot of times I also find inappropriate doses of medications. So for example, we may have patients that are taking gabapentin for neuropathic pain, but they're a dialysis patient and their dose is, way above maybe the dosing recommendation and the dosing range for these patients. And so sometimes we're making some dose adjustments based off of, renal function and other medications that could be interacting with those medications. I've seen a number of, incorrect DOAC doses as well, such as apixaban, and making sure that, we're maximizing the effect of some of these medications. And so this is really what I'm doing from an inpatient side when I'm analyzing these medication histories and making sure that we have valid reasons for maybe holding these medications versus, what we can maybe restart.
Thanks for sharing your experiences with NPs. How do you assist with transitions of care from an outpatient perspective?
So we have a very thorough transitions of care service at our institution. Back in 2018, we actually started a pharmacy resident-driven transitions of care service. And so based off of the great data that we saw within our institution with 30-day readmissions and how we were, optimizing medication therapy regimens at discharge, we actually got a funded position for a pharmacist to be our transitions of care pharmacist. And one of my colleagues is now our transitions of care pharmacist. And now we have a pharmacist that works full-time in transitions of care. She takes pharmacy students and pharmacy residents on her service, and they actually enroll patients based off a number of criteria. So if patients have high-risk disease states like diabetes, heart failure, or just recent admission to the hospital and they're a readmit, they fire to the transitions of care service to review to see if they are actually qualifying for services. Also, it takes into account the number of medications these patients are taking as well. So if patients are taking 5 or more medications and have other risk factors, they flag our transitions of care service to be evaluated. Some of these high-risk medications are also something that they look at from a transitions of care standpoint as well, such as insulin, anticoagulants, antiplatelets, and also sulfonylureas. If a patient does meet criteria for a transitions of care team to evaluate them, they will go and talk to the patients to see if the patient wants to be enrolled in this program. And then they will work on creating a medication list for this patient and really educating them on their disease state, educating them on their medications, even doing, health literacy assistance and kind of making things as easy to understand as possible for our patients. They also will look to see if there's any cost issues, to see if, patients are put on inhalers. Does this need a prior authorization? Does the patient need to be enrolled in a patient assistance program? So they do a number of great things on the inpatient side from that transitions of care team. Outside of the transitions of care service, we have an alert that fires to pharmacist at discharge that the discharge medication reconciliation is available to review. And the pharmacist will look over these medications that are being prescribed at discharge and kind of see what's the patient been taking, at home, and then what did we kind of change in the hospital, and see if all of that kind of adds up. We'll also look to see if there's any high-risk medications that, maybe require prior authorization or are not covered by insurance. And if there are cost issues, we'll find those prior to discharge and address them. We'll switch therapies, provide them with copay cards, do any prior authorizations that we need to do. And also the thing that we do that's great about our inpatient transitions of care service is we do a 48-hour follow-up call where we actually call patients after discharge to make sure that they were able to get their medications and maybe even make their appointment. Sometimes we'll have to help patients, make those follow-up appointments because they may not be able to do so themselves. Outside of the transitions of care service in the hospital, we have an alert that fires to pharmacists on the floor at discharge for certain patients that, there's a discharge med rec that's available that needs to be reviewed by a pharmacist. So on the pharmacy side of things, we'll look over these medications that are being prescribed at discharge and kind of compare that to what the patient was taking at home versus what they were on in the hospital, and really see if there are any discrepancies there, anything that we need to address. We'll also identify high-risk medications that may require prior authorization, such as inhalers or anything like that may be high-cost medications. And we also educate our patients on a number of medications at the request of the providers, or also if we identify any gaps in their understanding when we've kind of been talking to them about their medications. Also, I think it's very important for nurse practitioners and providers to understand their state's Medicaid website and formulary. This is something, in Tennessee, we have TennCare, and there's a nice TennCare website that goes over medications that are on the formulary, things that are kind of approved versus maybe won't be approved. We also have a list of medications that are free of charge. And so it's good to know, again, what your resources are, because you could potentially change a medication over to something that would not take up maybe a slot in their Medicaid list. And so I think it's good to know kind of what's approved and what requires a prior authorization as well. Other things to be kind of mindful of from a transitions of care standpoint is, does your hospital have an outpatient pharmacy? Are they kind of collaborating with another pharmacy that maybe provides medications at a discounted rate? Because this is something that, we can educate the patient on, or talk to them about, hey, do you want to fill your medications here, or do you want to continue to fill them at X pharmacy that you use? That's something also to be mindful of. Also, if you do have high-risk medications, there's a website called Needy Meds, and that's spelled NEEDYMEDS.com. This is a good website that kind of tells you if there's certain medications that are brand name that have patient assistance forms through the manufacturer. And so a good example of this is, some of our high-cost anti-epileptics that we prescribe for patients that have seizures. We'll sometimes look and see, is there patient's assistance out there for this patient, so that they can, get sponsored by the manufacturer. So that's a good resource for providers to have as well. And then GoodRx is also a good resource. Obviously, you probably see the commercials on television, but this is a good resource to kind of plug in the medication and see what the surrounding pharmacies are and what their kind of cash price is for certain medications. And they also will have coupons that kind of go along with their insurance to kind of knock down a copay. And so this is important to know, though, if they have commercial insurance versus if they have Medicare, because that may depend on if the copay card is accepted or not. It's also important to know if you have a free 30-day supply cards laying around in a pharmacy, or if you have access to those. But if you are going to use maybe a free 30-day supply, be mindful that they are going to need a long-term solution. It's kind of more of a Band-Aid. And we need to maybe address, is this the right medication for this patient if they're not able to fill it? Because samples and free 30-day cards can only go so far. I think also understanding test claims. And so something that is great about our pharmacy in the hospital is that we will oftentimes run test claims through our pharmacy if we get a medication that we're unsure if it's going to be covered or not, or what the copay is going to be. We'll prescribe the medication down to the pharmacy. They'll run it through the insurance and see what the copay is. That way, at discharge, we can have those discussions of here's what your copay is going to be. Do you think you'll be able to afford this? Do we need to search for maybe affordable options? So another good resource to look and see if you have access to is meds to beds. This is becoming way more popular in the inpatient setting. And so if you're unfamiliar with what meds to beds is, it's essentially a service where our providers will prescribe medications to our outpatient pharmacy. Our outpatient pharmacy will fill those medications and will actually deliver those to the bedside and educate the patients on those medications. And they will have those medications in hand prior to them discharging from the hospital. So this assures that, we won't send a prescription to X pharmacy and they may or may not go fill it. We are sending them out with the medications. And so we also mail drugs as well. So we can actually mail medications to patients if they have maybe transportation issues. So again, Meds to Beds is another good resource. If you have it in your institution, utilize it because it's a great resource. If you don't, look and see, is there something that can be done to maybe start a program if you do collaborate with a pharmacy, because this is, like I said, a great resource to ensure patients get the medications and maybe even address any issues such as copays and things, up front. If you don't have access to an outpatient pharmacy in the hospital, I think asking about, where they fill their meds and finding out which pharmacy to send those medications to. Some hospitals and outpatient clinics maybe have access to an external prescription database system to where you can see where they fill and how often they fill. So those are good things to be mindful of.
Heart failure patients are a very high-risk patient population when it comes to readmission to the hospital. What are some things that can be done to help decrease readmission for these patients?
Yeah, and this is definitely a high-risk patient population, and we see a ton of readmissions for heart failure patients, every day. Our list on my inpatient services is flooded with these patients. And so I think the first thing to kind of help with, readmissions is understanding what their lifestyle is. What is their diet like? What is their fluid intake like? Because I feel like, we have these medications, we have great medications that have come to the market in just the past few years. But if we don't educate our patients on lifestyle modifications first and foremost, then we're just going to be, getting really nowhere with the medications that we're adding on. So, making sure that our patients are, monitoring their salt intake, making sure that they are, limiting their fluid intake as well. So I think understanding kind of just a basic educational lifestyle modifications is the first and foremost thing that needs to be done. Outside of that, we need to make sure that patients are on the right medications. So, I think in the past few years, we've seen a number of new medications kind of gain steam. And I think, for example, our SGLT2 inhibitors that were primarily used in diabetes, but now we're seeing them used a lot more in heart failure patients. And there's actually great data to support their use in reducing heart failure readmissions and even cardiovascular mortality, depending on the type of heart failure that they have. And so I think, there's been a ton more use with these SGLT2 inhibitors. Oftentimes these medications are expensive though. And so this is kind of where I'll tie it back into things that I've mentioned earlier in the podcast, like understanding your state's Medicare formulary or their Medicare formulary, determining if the patients need a prior authorization for these medications, if they were going to start, an SGLT2 inhibitor. I think this is some good information that, you can kind of address on the front end. I know our cardiology department here at MUH loves putting patients on SGLT2 inhibitors. And so we're oftentimes trying to find out, is it going to be affordable for this patient or not? Because again, like I said, medications are great, but if you can't afford them, then you're not going to be able to take them and you're not going to get that benefit. And so understanding any barriers that there are, and if there's things that we can do to maybe overcome those barriers is something that we need to address, before we really prescribe these medications and expect our patients to take them. Other medications like Entresto, we're seeing lots of Entresto use now as well. So Entresto is the combined angiotensin receptor blocker with the neprilysin inhibitor that is kind of gaining a lot of steam in heart failure treatment and has, gotten great benefit in heart failure with readmissions and mortality. So a lot of our patients are being switched to Entresto. So again, like I said with the SGLT2 inhibitors, understanding what's cost going to look like. Is the patient going to be able to afford this? The other thing with Entresto is it does lower blood pressure more than our ACE inhibitors and our ARBs that we use. And so is the patient going to even be able to tolerate this from a blood pressure standpoint? Those are questions to kind of be asking as you're prescribing these medications. And then I think also that's important is, do these patients have follow-up? Do they have a primary care provider that's established? Is somebody going to follow these medications that we're prescribing? And the other important part is that we have primary care follow-up. And so do these patients have somebody that is going to follow up on these medications that's going to titrate these medications? Because, as you know, with heart failure, we have to get to certain goal doses to see the benefits that we're expecting from the medications. And so there has to be that follow-up piece. And I think that's probably the most important piece is that we get these patients in clinic, that we have somebody monitoring their medication therapy, as well as kind of monitoring some of those lifestyle modifications that I mentioned earlier as well.
Thanks for taking the time to chat with us today, Tate.
It's my pleasure. Thank you guys so much for having me on.
And thanks to all of you for listening today. We'll see you next month for our next episode of the Nurse Practitioner Podcast. For more great content from the Nurse Practitioner, be sure to visit us online at tnpj.com for the latest NCPD articles, columns, updates, and much more. This podcast does not constitute medical advice and should not be taken as such, and does not replace professional judgment or advice. The ideas and viewpoints expressed in this podcast do not reflect the official position of the speakers, authors, affiliated organizations, the Nurse Practitioner Journal, or Walters Kluwer. Please note that the hosts of the Nurse Practitioner Podcast are not clinicians. However, we created the Nurse Practitioner Podcast to bring you relevant clinical information by NPs for NPs. Thanks for listening.